Harper. Okay, you're all very welcome today. And look, I'm very, very happy that we're doing this briefing webinar for today. I'd like to welcome everybody today. We have a range of stakeholders who are attending, who are interested in these post-mortem guidelines, because they do cover a wide array of situations that are happening in the hospitals. And we're also aware that we might have some of our private hospital colleagues who we invited onto the call as well. So you're all very, very, very welcome today. I won't go over the full history of why we requested the 2012 standards to be updated, but I'm sure people can appreciate there is a significant focus on postmortems and the role postmortems play within the overall end of life and death piece within hospitals. So it is a very, very important area. And obviously there has been some queries, I will acknowledge that, about the application of the 2012 standards. But as we know, this piece of work is very much building on the previous standards, which are now over 10 years old at this stage. But also, in addition to that, we know the human tissue bill is fast coming down the track at us. And so there is going to be issues raised by that we need to think about when it comes to the post-mortem situation. We also know that there's been advances in technology and practices. We have a growing hospital-friendly hospital program across our hospitals. So in all of that, it was very, very good to refresh and update the standards as was necessary. And I'm actually overjoyed that the process, and Linda and Juanita will talk to this in a while, it did contain a very strong patient and advocacy element within the guidance development process. So I think one of the strengths of these new postmortem guidance is, number one, the plain English in which it's written in the question and answer format. But in that respect, it's not only useful from a professional's point of view, but it's actually very, very usable, these postmortems, by the families who will be going through a postmortem. So it's very, very important that we think about the implementation and the progression of these standards. And I suppose just to kind of emphasize that these postmortem standards, they do fit into a broader approach within the HSE that we're trying to focus on when it comes to end of life care. We can debate whether the lessons we've learned from COVID or not, but we know we are trying to advance many aspects of our end of life care through our national structures, but also just to let people know, and I'm sure you've heard the radio adverts for us as well, the HICWA survey, which is obviously HICWA, the Department of Health and the HSE, but the National End of Life Survey is currently going on. And we know that additional issues will come from this related to post-mortem care. So in some respects, these post-mortem standards are very, very timely. So in all of the things that we're going to talk about today, what we're going to be actually focusing on, as much as the post-mortem standards, is giving you some information on us developing a mortuary improvement program within the HSE, because very much these post-mortem standards or guidances will fit in within that broader mortuary improvement program that we want to progress. And ultimately, we know that this will fold into a requirement for investment and a business case associated with progressing our end-of-life care, particularly within the mortuary services. But I just want to note that also we will touch off things like, for example, the continuity between these guidances and the coronial post-mortem processes. So again, just so people are aware, we are involved in a group with the Department of Justice at the moment, looking at a better approach and a more enhanced approach for coronial post-mortems and a sustainable approach to coronial post-mortems. So again, we're just conscious of that as a typical, or as a thing that we need to factor into our thinking. And also, for example, just things like, for example, mass fatality planning. The tragically increased law kind of highlighted the fact that mass fatality and mortuary provision can be something that comes at us on any particular weekend. So there's lots of going on in this space. So as I said, today is very much just an information session to let you know about the guidelines, the changes, the available support material, and how we intend to proceed around the implementation associated with the post-mortem guidelines. Again, emphasizing the link between these guidelines and a broader mortuary improvement program in the context of the human tissue bill. And we do recognize that a formal implementation process is required for these post-mortem guidelines. So look, the one thing I would ask is people just to kind of think about the fact that actually we're not just positioning these and off you go in terms of implementation. We know that they do need to be supported. So our plan broadly is to hold a planning session at some stage in the future to think out what's the best approach to a mortuary improvement program, because we know these guidances in this particular context are going to need training. We know our mortuaries require thinking about in terms of capacity, the facilities, the business processes, how mortuaries are networked, the bereavement support associated with them. So we were thinking of holding an information or a planning session in the near future. So if anybody's interested, I would appreciate it if you want to either email me directly or to put your private message me via the chat function there, in terms of if you're interested in sitting down as part of a group to see what's the best way we could structure a mortuary improvement program. We have a draft planned currently, but we would like to kind of think about all the various different elements when it comes to the mortuary. So if people are interested, I'm very, very much interested in hearing from people who'd like to be participating as part of that kind of almost pre-planning session. So as I said, how we're going to run the session is we're going to run through a brief update on the post-mortem guidances, its main changes, how it will function, and then we're hoping to open up into a panel discussion with our panelists today. So again, just to encourage you, on the bottom right-hand side, you'll see the chat function. You can put in your questions as we go, and we'll pick them up later on or at the end if you want to put your question in there. We'll pick it up there. People can feel free to put in their name and their institution and their work role, so people can get a sense of who's on the call as well. We'd appreciate that, because there's so many different stakeholders involved in post-mortem processes. And the one thing I would ask maybe for people when they're asking questions, if you don't mind, is this probably isn't the best forum for individual service related queries. For example, if you're saying, I work in X hospital and we do it this way, or we don't have that, that probably isn't going to be a benefit. And this is not really the purpose of the kind of webinar today. What would be very, very beneficial from that point of view is if you thought about your question in a general sense. If you didn't have this, or if you approached our service, if our services do this in one particular way, how would they cope with this in terms of the post-mortem guidance? So rather than specifically concentrating on your own individual services, we would really appreciate if people would take a broader view in terms of the general questions, and hopefully then we get to the individual services questions when we move into the implementation stage. So just to introduce our panelists today, I'm very happy to introduce Marie Cregan, who was one of our patient partners from Patients for Patient Safety Ireland, and Marie was integrally involved, but a lot of different patient involvement processes were taken as part of all of this, but Marie is on today to represent the patient piece. We have Dr. Myra Cullen, who's the coroner, who will also be able to take questions, but also has been a huge linkage between this process and the coroners as well, to make sure we're in step, because again, we know the interdependency between our post-mortem service and the coronial post-mortem processes. We also have Sabrina Mullally, who's a senior pathology technician in Limerick. And again, Sabrina was integrally involved in helping us develop these post-mortem guidances. And then our main presenters today are Professor Linda Mulligan, who is the chair of the review group, and Juanita Gadera, who's from our National Patient Safety and Quality Division. I'm very, very grateful to Linda for taking on this piece of work, and the professionalism and the depth and the comprehensiveness at which Linda went at this project. I do lots of work with Linda, and she's involved in a lot of different projects with the HSE. I'm regularly on the phone to Linda. So as far as I can, in her spare time, Linda happens also to be the chief state pathologist, but most importantly, from my point of view, Linda is absolutely fantastic to collaborate with. She is so positive and brimming with the can-do attitude. She is an absolute joy to work with. So I'm very, very happy that Linda was chosen by the faculty to progress this piece of work. And as I said, she is absolutely fantastic to work with, and we're very grateful. And ditto, I could say the same about Juanita Deguera and Maureen Flynn from our National Quality and Patient Safety Division, who are very, very collaborative to work with, and it's such a positive experience. And the depth and, as I said, the breadth of work that was done to actually bring these guidances to forward was fantastic. So just to remind people again that this is, when we talk about this in terms of implementation, this will be part of a broader mortuary improvement program. And again, the human tissue bill, even though it's not passed, we have tried to anticipate as many of the issues within this process as possible. So if that's all okay and hopefully clear, I might pass back to Linda to progress.
Well, thank you, Kieran, for that lovely introduction. A little bit embarrassed, but that's really nice. And it was a pleasure from my side to work with all of you guys as well. And this is something that's very close to my heart, obviously. So it really meant a lot to be asked to do this. So essentially, what I'm going to talk about is the overview of the work that the review group did. And just to reiterate what Kieran said, there was a very substantial building block already there in the form of the 2012 document, which provided a huge basis for us to work from and gave us a lot of the essential basic information that we could build on using the challenges and changes that had presented themselves over the last 10 years. We also then wanted to mention the fact that the booklets that form part of our toolkit again had a good foundation to build on, and technicians around the country, and particularly in Cork University Hospital, were very open about providing booklets that they already would use, and in particular around the perinatal and paediatric services, Our Lady's Hospital, Crumlin as well. So I probably will forget to thank somebody, but they were instrumental in providing the basis for those booklets too. And again, just to reiterate from what Kieran said, the NQPSD people, that they were an amazing group of people to work with. I learned so much, and they were a very important partner to support this work, which was commissioned in response to an awful lot of audits and investigations that have been done over the past few years. So if we can move on there, Chris, please. To the next slide, thanks. So this is an overview of the review group and its members. And as Kieran has already said, we had a very important patient representation on the group, which was hugely helpful, and they had a lot of input, and it really opened my eyes from a pathologist point of view as to what we were doing this for, and that the post-mortem examination service isn't just for the dead. It is also very much an important process for the living and part of the grieving process. So the review group was commissioned. There were 26 members, 1 note taker, and then 2 observers as well. We had 5 meetings, which began in June 2022 and followed through to January 2023. We were originally planning on having, I think it was 4 drafts, but we ended up having 7 drafts based on feedback from the review group and other feedback that we got throughout the consultation process, which I'll talk a little bit about in a minute. And both were hugely influential in how we formulated the document. So thanks to all those who were involved. As I mentioned, we also developed a toolkit. So the toolkit is composed of a lot of different forms and documentation processes that should either, they may already be in place in your local hospital and your local practice. These are just a guideline to show you everything that needs to be included. So you may not necessarily need to replace those forms that are in place and being used already, but what this toolkit is intended for is to help you to make sure you're including everything that needs to be included. And all of this was informed not just by the diverse expertise that was on the group between clinical staff, nursing staff, management staff, coroners, APTs, etc. It was also informed by a literature review. So it's very important these days that anything in medicine is evidence-based, and the literature review was endorsed by the Faculty of Pathology at the Royal College of Physicians in Ireland and will be available on their website. And just to mention, Dr. Vaughan McCartney and Juanita, you might help me out here. The PhD student whose name has escaped me right now, but
Trina,
yes, thank you, Trina Nicholas. She was they were vital to performing the literature review, and they really had a huge input into it. So that provided the evidence base for our document. So I might move on to the next slide, Chris, please. Thank you. So this is just an overview. They're very busy slides, but just to show you exactly how much work went into the consultation process. So we did focus consultation with several groups, which commenced in August 2022. And this involved having a webinar that was kind of an introduction to the whole process. And then whoever needed to join our regular meetings was brought in as needed. We also emailed them a letter and kept them informed of the copies of the drafts as we progressed. The webinar that we provided was actually pre-recorded, so it was available to people if they needed to go back and have a look at it again. So that was our focus consultation. And then we did quite an extensive targeted consultation, which began the 19th of September. This went on for 4 weeks. We had 54 responses, and we did extend the targeted consultation for some smaller groups as well, to give them time in order to provide their feedback, which was, all feedback was considered vital to the development of this document. Again, there was an email sent with a letter from myself, the chair of the group, a copy of the working draft that was there at the time, and a link to the pre-recorded webinar, which informed people on what was required of them and what kind of input we needed from them. We did some additional consultation then through the HSE National Patients and Safety Forum and users, and just to mention as well, Corja and all of the patient representative groups that provided such huge input into the document. So if we can move on then, Chris, to the next slide, please. It's very important to mention as well that throughout the course of this work, we realised that the post-mortem examination services rely heavily on other policies within the HSE, and they were also being developed concurrently. So the HSE National Consent Policy 2022, and then the HSE National Policy for Consent and Health and Social Care and Research, which was 2023, published this year. And we worked very hard with the teams from both of those projects to try and align the post-mortem examination guidelines with what they were what they were providing around the whole concept of consent and communication with families. The care of the deceased guidance is also in discussion at present, and again we try to align the new HSE guidelines as much as we can with these documents. And we also used the Royal College of Physicians guidelines for post-mortem consent and retention of samples, which were published in 2000. There are some ongoing programs of work. Kieran's already mentioned the Mortuary Improvement Programme, and there's also an ongoing piece of work to respond to the national audit. The care of the deceased guidance is ongoing. And just to mention as well, the Human Tissue Bill, which was published in December, I think it was 2022, that is due to go to committee stage imminently, as far as I know, but a lot of work has gone into that. The Human Tissue Bill itself deals with the consent process in consented hospital post-mortem examinations, but it also touches on the authorisation and consent around management of retained organs in coronial post-mortem examinations. But we won't talk too much about that here. Our focus is on the guidelines today. So I'll get you to move on again, Chris, please. So this is just an overview to show the two booklets. So the first one, the HSE National Clinical Guidelines for PME Services, is broken down into 8 separate parts. Important to highlight that there are major chapters on the consent and communication around post-mortem examinations, both from the consented post-mortem examination and from the coronial post-mortem examination point of view. It also deals now with community deaths and gives some guidance on how to deal with those in the HSE facilities around the country. We have provided as part of this booklet a flowchart which can be printed out in A3 format, which will be helpful to have in any situation or any department that deals with post-mortem examination services on a regular basis. And it also deals with timelines around management of retained organs following the post-mortem examination process. As I mentioned, the toolkit of templates, this is quite a comprehensive booklet. Again, there to provide guidance on what should be happening at a local level with regards to consented and coronial post-mortem examinations around communication with the family and the coroner. The forms and protocols that you already have in place may well be adequate when you have a look at this toolkit. So don't feel that you need to change things that are already working really well and already have a documentation process in place. Again, if you move on there, Chris, please. These are the template booklets that we've again provided as a guidance. Obviously, practices are going to differ in each region and in each mortuary. So it's important to know, again, these are guidelines, and these are there to help you formulate a booklet for the individuals and families that you're dealing with in relation to bereavement and post-mortem examinations. So yes, so these are all available, just to mention as well, on the Linus system. And this is an open access system. Just to mention as well, when you go in to look at the toolkit of templates for the PME services, you get sent to this screen here with the yellow arrow on it, and you do have to click into view more files to access these documents in Microsoft Word and PDF format. So that's a kind of it in a nutshell. It was an awful lot of work over, I think, about 9 months. And hopefully this will be very helpful to everybody involved in the provision of these services to bereaved families around the country. I think that's me finished, as Chris might.
Thank you very much for that,
Yep.
that overview. And Juanita's going to just do a high-level overview of the key changes, folks, so just you can get a sense of how these have changed in terms of the guidances. Again, I would just encourage people as we're going through to put your questions into the chat function so that we can address any of the issues or things that people might want either more clarity on or more information while we have our panelists here today. So just to encourage everybody to start putting their questions, and then we'll do a roundup at the end to put some of your questions to the panelists. So over to you, Juanita.
Thanks very much, Kieran. And thanks to Linda for the introduction. We might go on to the next slide, Chris, if that's possible, please. Thanks. So just to say, this is sort of a whistle-stop tour. It's not a training session. The training will come, but it is sort of a high-level overview of some of the key changes. And just to give you a sense of what's happened. So the first thing just to say is sort of some of the resources, we've signposted them within the document. And in particular, probably the thing that's of most use within the document, as someone described it, is there is a process map. And that process map is also available to print out in an A3 format. And it's really helpful to have that locally so that you can determine if it's a coronial postmortem or a hospital postmortem or a state case, what are the sort of the key areas within that that need to be addressed. The other thing to say is that obviously Linda's spoken about the development of the accompanying toolkit and forms and the booklets. And just to say, within sort of, I suppose, those forms, you will see sometimes multiple versions of the same form. So in particular, say, for example, with a hospital postmortem or a consented postmortem, you'll have two versions, a short and a long version. And that's to allow for the fact that in some instances, it may not be the same family member that's consenting different parts of the process. And part of that has to do with the two-stage process as part of a postmortem where somebody wants to consent to research or medical education as part of that piece. And you'll see more information on that within the document, but just to say that there are short forms and long forms. And the other thing we've allowed for is an additional form for community. And the reason for that is that sometimes the initial conversations around the postmortem happen before the person comes, before the family come to the hospital. So it's depending on how it happens locally. And you can choose then which form is most applicable depending on the needs of the family in that circumstance. I suppose just to say we have an updated glossary and reference lists. And they're all there, but equally also the literature review is there that people can look at that if they're looking for more information on the data that informed the actual updates. That's all there. And we also have a local standard operating procedure page. This came as a suggestion from one of the services who said that it would be really useful to have on a page all of the things that you might need to think about locally. So obviously this is high level guidance and clinical guidelines to support you, but there are local procedures that are going to be required to determine what works best within your setting while adhering obviously to the clinical guidelines. And that list of the local operating procedures allows you to look on a very quick level to see what do we need to be thinking about here. And chances are you will have a lot of that in place already. As Linda said, if you have forms that are working, you don't need to change them. It's just these standard templates are there to support you if necessary. We might move to the next slide. Thanks, Chris. So in terms of the document itself, the formatting and layout has changed probably considerably on the last version. And obviously, a lot of the information you'll see will be standard. But what we've tried to do is use a question and answer style where possible, because where possible, back to say that that's helpful for people that are trying to find information in a hurry. The other thing to say, it's a PDF document, so it's searchable. So you can type in the phrase that you're looking for into the search function, and you can also use the table of contents and click on that to bring you to parts of the document. The other thing we've done is we've amalgamated the coroners and hospital post-mortem data, and we've color coded it. So what you'll see is on the left-hand side of the page, information on coroners, and on the right for the hospital, and they're color coded. Now, that doesn't work if you've got a black and white printer, as in a lot of instances we do, but at least you'll be able to look at it online and see the color coding. We had a lot of debate about whether or not we would have two separate documents, so one for coronial postmortems and one for, and what we found is that chances are the staff who are going to be addressing this are working in the same area, and the need to go to two different documents is actually going to slow people down. So what we've done is to try to amalgamate it to make it easier for people to access the information quickly. The other thing we've done is use tables to upfront or provide clarity on data. For example, in particular around consent, that information is there, and you can use that and use tables to support it. And the other thing as well is just to say there had been information on training merged throughout the document, and we've amalgamated that into one section at the very end. Thanks, Chris. We can go to the next slide. So just to say, I suppose one of the key things that we've done is in terms of the key roles, so a designated person or role for tracking, overseeing and monitoring of organs in all postmortems in each mortuary. And a designated family liaison, so somebody potentially from the multidisciplinary team, bereavement support, etc., who would be a key liaison for the family. Chances are a lot of services have these roles in place already, but what it does is it formalises it so that it's very clear who is the key contact for a family in the case of a hospital or a coronial postmortem. The other thing we've done, I suppose, is in the absence of family instructions, this is probably quite a significant change. Sometimes in the past, in a situation where you haven't got clear instructions for the family, or there's a delay in the family providing those instructions, we have had a retention of organs for an extended period of time. And in order to be respectful for the individual, what we've done is put in place a 1 year and a 3 year time frame. So that 1 year time frame, so say for example, if a family following repeated contact hasn't given clear instructions and doesn't intend to, in that instance is a 1 year time frame, and at the end of that 1 year time frame, following a local procedure that's developed locally in accordance with these guidelines, there is an option then for the organs to be managed to be buried or cremated as is in line with the local procedure. And if it's a thing that the family members have engaged, and say for example they've said yes, we'd like the organs buried, and then at the time that it comes for them to be buried, it's not possible to contact them. Again, at that particular point in time, there's a 3 year time frame. And if after the 3 year time frame, despite repeated efforts to contact the family, then the hospital may arrange for the burial or cremation of those organs as necessary. And what it does is it allows for the respectful management of those organs. And I think it's very important to mention that if the family is engaging and it's just a delayed process, that's fine, then we continue to engage with them. But if there's no engagement, despite our continued repeated efforts to contact them, in that instance, then there's time or an opportunity to do that. The other thing, I suppose, within this guidance that we've sought to do is to try align it with the care of the deceased guidance, which is pending, the National Consent Policy and the National Policy for Consent in Health and Social Care Research, and also the Human Tissue Bill. Now, the Human Tissue Bill is in progress at the moment, but where we've had information available, what we've done is we've sought to update the document to take those things into account. And I think in particular our thanks to the teams working on the National Consent Policy and the research who gave an extraordinary amount of time to try support the development of these guidelines. We can go to the next slide. Thanks, Chris. So some other key updates to the document. So there's been significant update to it in terms of perinatal care, so that there's additional information to support staff who may be involved in perinatal cases. We've included information on minimally invasive PME, which may not have been as prevalent at the time of the initial documentation, but I think also to mention around the minimally invasive PME that we've also acknowledged that it requires specialist equipment and it can be dependent on the circumstances of the case and also the availability of that equipment to support it. We've included information on the community deaths. So in particular, if you have somebody that's brought in death, said, and how that process can be managed, and also the Garda identification principles of care. So there's an appendix in there around the principles of care, and that's, I suppose, just so that a conversation can be had with maybe Garda that might be coming onto the ward. There's often a lot of fear from families or concerns that they might be accused of something if the Garda are involved, and they don't recognise that it's part of the standard process of postmortems. We've changed the language and moved away from the disposal of organs and moved away from sensitive disposition to the sensitive management of organs, or burial or cremation. And what we found is that people maybe understand more clearly if we're talking, I suppose, in real terms, so burial or cremation, it's understood more clearly for people. We've included a piece on organ donation so that the option is there. And in particular, I suppose what we've said is that, we don't generally have conversations about post-mortem examination in advance of somebody dying, unless it's their wishes or it's raised by the family. But in the cases where you have a situation where somebody has expressed very, clearly that they would like to be an organ donor, that those conversations can happen early to see if that's possible in consultation with the pathologist and the coroner, if necessary. There's guidance in there in the event of a lost or misplaced organ, and following the local risk management guidelines and so on, but just to be able to say that there is guidance in there and hopefully that wouldn't be an issue. And also the inclusion of information electronically. And ideally, where possible, we should be using electronic records. In some smaller services that may not be possible, that there is sort of manual registers and so on, but there is guidance there on the move to electronic record keeping where possible. The medical and the coronial responsibility around communication. So in particular, there was a lot of debate about if it's a coroner's post-mortem, where does the responsibility lie? And the group came to the conclusion that in the vast majority of cases, the conversations happen with the medical personnel in front of the individual, and you don't want to delay having a conversation with somebody if they have immediate questions. And in that regard, a lot of the responsibility in this instance sits with the medical personnel that are meeting with the families. And obviously the coroners may provide additional information at a later stage, but if the person is in front of you, we wanted to maintain, out of a duty of care to the individual, that they're looked after. And the other thing was around the wording to include or reflect the independence of the coroner's office. And in particular, there might have been consideration around if there is an immediate need. So say, for example, in particular in perinatal cases and somebody wants to get pregnant again, there might be an immediate need for results to be shared with the individual. And that is done in consultation with the coroner. So the pathologist can contact the coroner, have a conversation, so that the lines of communication are clear, because obviously the coroner is independent in their function, and it's very important that we maintain that independence, but equally at the same time it's recognised that in some circumstances there may be a need for an earlier conversation to happen with the family, and it's just allowing for that consultation to happen. Okay, we can go to the next slide. Thanks, Chris. Okay, so in terms of consent, this is probably one of the most significant changes within the document, because obviously when the initial documents were developed, there wouldn't have been a national consent policy in place, and there wasn't a research for consent document. So just to say, we acknowledge that the consent policies at the moment are obviously written for the living, but obviously the principles are as applicable in this circumstance as for the living. So what we've done is we've updated it to reflect the principles within the national consent policy, and just to say that in the next iteration of that document, it will be updated to reflect post-mortem examination. The age of consent has been left at 18, and that's something that's been done in consideration of the Human Tissue Bill and the changes there. The use of the word consent for the management of organs in coronial postmortems will probably be a new change for some people. So obviously we don't give consent for a postmortem that's a coronial postmortem because it's mandated by legislation, but there is consent that's required in relation to the management of organs. And also if somebody wanted to, I suppose, avail of research for consent or medical education, that's permissible, but there's consent processes that are required around that. And that's in line with the Human Tissue Bill as well. Defining who may take consent in terms of hospital and community cases, and there's a significant section on that, so I won't go into it in too much detail, and advanced decision making on consent for post-mortem versus the conflicting family wishes. So say, for example, at the moment, the legislation, it's the Anatomy Act 1832, it's quite old, but somebody can give advance permissions for post-mortem, but if the family objects at a later stage, then the family wishes are adhered to, and that's in line with the legislation. That's likely to change with the human tissue bill. There is information on the options to withdraw consent as applicable. The definition of family and that hierarchy that would have been in the previous documentation has been updated to reflect the Human Tissue Bill thinking and also the Coroners Act. And also in terms of the assumption of capacity in good faith. So we don't use capacity assessments in postmortems because it could be very, very onerous for a family. And also, obviously, there's a time-sensitive piece that's required. So the conversations, there's a hierarchy that's there that supports decision-making in that instance. And obviously, we do our best to make sure that if somebody has capacity at all, that they're involved in those conversations. There is a section that's been updated to reflect changes in the event of a care order, and again, TUSLA wouldn't have been in existence when the initial documentation was there. Initial documentation was developed, so that has been updated to reflect who has legal responsibility in those circumstances, or in the broadest sense, the ideal is that it would sit with the family where possible, and also ward of court. So it's been updated because once a ward of court has died, the committee is no longer recognised legally. And the designated family member is identified in that circumstance. Okay, so thank you, Chris. We can go to the next one there. Okay, so just to say that's a whistle-stop tour in terms of the changes. There will be additional training that's available to people at a later stage. But it's also probably just helpful to mention that there are some things that are outside of scope of this guidance, and this would have been something that would have come to light as part of the consultation process, and we just wanted to share those with you. So from a resource perspective, in terms of the coronial service, the implementation and upcoming legislation, the Mortuary Improvement Programme, responses to national audit and the care of the deceased guidance, there are other processes in place to support the development of the Mortuary Improvement Programme that are outside of the scope of this particular document. But I think that in terms of the document itself, there's a lot in it, and it's quite comprehensive. So I'm going to pass over now to Kieran, who's going to talk a little bit about the implementation, and then over to the panel to give you an opportunity to ask any questions that you might have. Thank you.
Thanks very much, Linda and Juanita. That was very, very comprehensive. And I hope folks, again, to my mind, the post-mortem guidances are very, very clear, even the way they're written, the way that they're framed, the question and answer style. So we hope that they progress from the 2012 standards and provide a lot more clarity and a lot more scope for post-mortem services. So from my point of view, I'm very, very happy with where they've ended up. Again, just to speak very broadly about the implementation process, and again, to reiterate two things. Number one, we hope to fold these post-mortem guidance implementation process into a broader mortuary improvement program, because we know post-mortems are only just one element of all the business processes within a mortuary service. And again, just to reiterate, if anybody's interested, because we do intend very shortly to hold a planning kind of group to think out this best structure for a mortuary improvement program, factoring in all of the different things I talked about in terms of business processes, facilities, training, communication, all of the different elements. So if anybody's interested, please either email me offline or private message me via the chat function there if you're interested in being part of that. But broadly, folks, we know the next steps are required. We have issued out the post-mortem guidances to all of the hospitals via the hospital groups. We will be expecting shortly each of the hospitals to appoint an operational lead to help us in terms of have oversight and to help kind of work with us to progress the implementation of the post-mortem guidelines. We do expect each of the hospitals to undertake some form of review of the current practices against the guidance and to look at to what some of the local improvement approaches that do need to be put in place. But again, I want to be clear and I want to emphasize the fact that we understand that this will require to be supported by the acute operations in terms of its broad implementation processes, either through the development of a standardized training program, as I said, probably unlikely the scripting of a business case for investment in mortuary facilities and mortuary services generally across the system to allow better compliance with these guidances. And as Juanita mentioned also, look, it'd be very prudent, and we've put the business case to our eHealth partners around a comprehensive information system to support the care of the deceased generally, and all the documentation and all the interactions with the coroners and the guards. It would be prudent at some stage to think about a better technological solution in order to facilitate that process. So broadly, what I'm trying to say is that there will be an implementation process, and it will be a collaborative process with the acute hospitals that we hope to progress very, very shortly. So in respect of that, we were going to then open this out to the panelists to ask some questions. So again, I would love people to be putting their questions in the chat function so we can pick them up and address anything that's outstanding. Although again, I emphasize that I think the way that the postmortem guidance is written is very, very clear. Not to make a pun, but also to consider this post-mortem guidance document to be a living document as well. So look, we expect as we go through the implementation process that issues will arise, and the post-mortem guidances will be required to be updated as we go along. But as a first starter, it is fantastic that we have this new guidance document. But again, if we do begin to pick up issues locally during implementation, I want to kind of stress the fact that we do expect the guidances to be either tweaked or changed and to be revised into the future. So I might just start with a few questions. We were very, very happy that Marie Cregan from our patient partner and Patients for Safety Ireland was part of the process. And even from my point of view, for Patients for Patient Safety, to be even looking at the death processes was really, really an important signal overall for what you consider to be an important area of focus within the broad healthcare system. But you might give some really just like, why was it so important to you that you be involved, or Patients for Patient Safety be involved in this process, and what difference do you think this work might make to the broader post-mortem approach?
My involvement it was twofold really. One, apart from patient safety, I'm one of the founder members of Féileacáin, and that's the Stillbirth and Neonatal Death Association of Ireland, and post-mortem would feature very highly in some of the distress that our parents who bereaved perinatally would talk about, you know. But also, I suppose, as a family, we've had 4 different experiences of post-mortem, and each of them couldn't be different. My grandson met with his parents met with the pathologist, and the fear and the horror around post-mortem, because the term itself strikes fear into your average person. But they met the pathologist, they knew how their infant was going to be cared for, and it was a much more, I don't want to say positive, but much less upsetting experience for them. Whereas when my daughter died, when she was stillborn, I wasn't encouraged at all to have a post-mortem, because I was told, well, you know, we're going to find out what took her. But I would have found out what didn't take her, you know. And I suppose the main one for us was when my sister died, and I was her carer, as our mother had died young. And she was being aggressively treated for the disease that took hold of her. It was MRSA actually, and they were hoping that they had cared for her enough that she was going to be okay. But between Sunday and Wednesday, it was obvious she was going to die. And Saturday, we were told by her team that they were withdrawing care, which was traumatic enough. But the consultant on call asked to see me, and it was outside the door of her side room that he said, look, we're going to have to talk to the coroner because she's so young, and also we're going to have to perform a post-mortem. Now, I was absolutely horrified. There were people wandering around outside. I don't know what I signed. In my eyes, it's my mind's eye, it's a yellow form. I know what I signed. I signed whatever he wanted me to sign. But no one came back afterwards to say, what questions have you? No one asked me, was I okay? And it was absolutely shocking. And I'm not someone who's easy to upset, but I just feel we all know how important sensitive communication is. Everybody knows that, but hospitals are busy places, and boxes have to be ticked and processes have to be followed, and sometimes the communication gets lost, that you're talking to people who are totally outside of this milieu and they don't understand it, they're frightened by it. And the effect for us, like, it came down the months and the years after her death. I feel I abandoned her. I was planning to take her home and lay her out at home, and I didn't know where she went after she died, and they allowed her to die in my arms, but she didn't, my head was on, where's she going to go next? Who's going to look after her? Who's going to mind her? And where's she going to go? And no one came back to ask. So it was that piece of communication that was coming up in the processes, in this particular process, and the fact that they were listening to patients is what drew me into it. That's a very long answer, and I'm sorry, Kieran.
No, Mary, that kind of, it resonates with all of us, I have to say, sort of thing. And look, to my mind, the way even these postmortem guidance are written, like a family might be able to download them and make sense of what they expect as a service as well, sort of thing, as probably compared to, not trying to be unfair, the 2012 standards, which were very technical in nature. So this is very clear language. So again, we hope that both the leaflets and the standards, or the guidances themselves, are also actually clear about the expectations, for a service for a family.
And the key liaison person, it's going to just make it so much easier and less traumatic for families, I think.
Exactly. And I know Deborah has a question in there around that. But just Myra, I'm just conscious of the time, just the coroner's point of view, do you think this will improve the communication and the processes between the coroners and the hospitals when it comes to the coronial postmortems?
Yeah, I think this is a very important document, and certainly it's going to improve the interaction between the coroners around the country and the various hospitals in which they direct autopsies to be conducted. I think you have to remember the vast majority of postmortems in this country are coroners' postmortems. And so this document is important from my point of view for four main groups. Firstly, the families. So I would echo what we've just heard from Mary. It's going to be very good in relation to communication for families and explaining to them the purpose of any post-mortem, timelines, and they'll have clarity in relation to the potential for organ retention, the handling of the material, and they will understand now the consent process, which sometimes isn't fully understood in terms of not requiring consent for a coroner's postmortem. But just because consent is not required, that doesn't mean full information is not required. So full information is central. And then, of course, there is the consent element now too. If there is a requirement for retention, it's clear in terms of the family's wishes being observed, timelines being observed, and it's clear how the support staff will interact with the families to effect the proposed changes. So really what you want also is a standardization. So for families, they'll have the same experience no matter what part of the country they lose somebody. And ultimately, you want a better and more informed experience for the bereaved. The next persons for whom I see it as being very important, obviously, are the histopathologists. It's going to improve, and I can only speak about coronial autopsy, the interaction between the histopathologist and the coroner. We're going to move, hopefully, to more implementation of written authorization, formal authorization, and a formal continuity of record management from the beginning to the end of the process. Starting with authorization, including the post-mortem report, including any deviation, as was mentioned, around urgent exchange of information to clinicians. So I think that's definitely going to improve what goes on between a coroner's office and those histopathologists on whom they're so dependent based in hospitals. And the next group then obviously are the support staff, who one hopes will be engaged in implementing all these changes and improvements. And I think the process mapping, the toolkits, the new forms or suggested forms, if you don't have any already, that you can amend for yourself, that's going to be of great assistance. And of course, the main thing underpinning all of it is the way it's laid out. It's very readable and it's very clear. And then obviously the distinction between coroner and hospital is very clear in the document. And finally, then for coroners, will it improve the coronial autopsy from the point of view of a coroner? So from the point of view of a coroner, the expectation is that the families will be at the centre of the entire process, and they'll have agency. They understand the role of the coroner. It's all set out, and they'll understand, as I've said, around the consent process, where it applies and where it does not apply in law, and notwithstanding that they would have all full information. And so I think that there should be, between coroners and the hospitals now, a joint emphasis on improving the experience of families when sadly somebody belonging to them requires a coroner's autopsy. So I think it's all to the good. That's all I
That's
want.
great. No, I appreciate it. And look, picking up on one of just Tom Crotty's questions there, just Tom, like again, these guidances, I think hits a sweet spot between setting out a set of templates and shared information that will flow between different people involved in the post-mortem process. And we hope that'll drive the standardization and, more importantly, probably the point that you're trying to get at it, the familiarization across a range of disciplines and professionals within the system, so that if I'm a doctor moving between one and two or different hospitals, or I'm even in the hospital, the same form, that template allows you to build out a standard form that should become pretty stable over time, and therefore people will become familiar with it. So we're hoping that kind of that specification at least tries to put out the standard fields, the standard exchange of information, which hopefully will help and drive improvements in how those are completed over the kind of next few years. Just conscious of time as well. Sabrina, I might bring you in as a senior APT in relation to these post-mortem standards, and I know you were involved in their development as well. Just you might give us an idea from, because I know a lot of this is really, really good from both the pathologists, as Myra kind of suggested, and the APT's point of view. Do you think these standards will be a benefit, and what kind of the major areas of focus and maybe some of the barriers to implementation? You might give us just your thoughts on that.
I think the biggest change is going to be for mortuary staff is the implementation of the toolkit of the forms. It's going to be very helpful to us. I mean, we have the 2012 guidelines, and the audit that was done a couple of years ago showed that practices are generally good throughout the country in mortuaries. But the forms, the introduction of the forms will kind of facilitate and formalise written communication to and from the coroners. As Myra mentioned, there will have to be formal authorisation from coroners before postmortems are carried out. It will also allow easy access to any communication that's happened with families. We will know what's been explained to the families already if we do need to talk to them about retention of organs or anything like that. And finally, with the funeral directors, having a form to give them can only help. Very often, it's not necessarily the person that's collecting the deceased patient that carries out the embalming. It may not be that person that is speaking to the family. So to have something handed over that has all the relevant information will be hugely helpful. A possible barrier is the fact that most people now think that post-mortem guidelines and anything to do with post-mortems is solely to do with mortuaries and pathologists, but it's not. Everyone who speaks to families, everyone who is on the ward, medical staff, admin staff who are speaking with families about post-mortem examinations need to be informed. It's something that I kind of would have been perceived to be just solely a mortuary and pathology issue before. There's also a challenge of asking possibly people to do more paperwork. There might be a perception of a higher administrative workload, but I think there will be formalised implementation. There will be training for all hospital staff, and the introduction of these booklets and these forms will give consistency and protection for everyone involved in the process, and it will also give reassurance to families that they are being informed, they are being kept informed, and they understand what's happening.
That's great. And look, folks, I see questions now flying in, so we're going to just go till 13:35, given the fact that we were kind of a little bit late starting, if people are all right with that, which would be fantastic, because we do want to get to some of the questions that people are putting to us here. So I might just pick up some of those questions that are flying in for us, sort of thing. So I just see one there from Anne about the education for clinical staff and not just concentrating on the communication with families piece. So just again, and I think that's really, really important. Again, when I had said training, I hadn't meant that narrow band of just the communication around the post-mortem piece. I think we need to develop a training package that brings the different elements of this so that we can live the guidance day to day within the hospital. So just to give people assurance on that one, that I interpret a broader kind of approach to that. Linda, did you want to come in?
I just wanted to come in there because part of the literature review highlighted the fact that clinical staff and other staff outside of the mortuary usually benefit from attending a post-mortem examination at some stage, particularly if they're going to be dealing with families on a regular basis around bereavement services and post-mortem examinations.
Thanks. I just think Linda has frozen on us there. I'll just move on sort of thing, because I think what the point Linda was making was very important. Then there was just a question there from Deborah about the hospitals to employ a post-mortem examination liaison officer. Again, Deborah, just to say, I suppose number one, we're trying to champion or pioneer the development of bereavement support officers within the hospitals, but at the same time, we can specify that could be a range of different people. But I suppose people can understand the importance of a family contact in terms of the post-mortem examination service, and that will form part of our business case. But in the interim, I still think there's an expectation within the hospitals to have some person or people who are competent and trained in providing that role, because it's so important as the critical link between the post-mortem process and the family, bringing that. So look, so as you say, some people have these in place, but it is guidance at the end of the day. We can't, to bring up another point that's been made on the questions, we can't force anybody. These are not mandatory, but they do represent best practice, and it is an expectation that we would be living best practice. Now, I know that kind of, I'm kind of speaking out of both sides of my mouth when I say that sort of thing, but at the same time, we are going to encourage the hospitals to progress the implementation of this guidance, and it does represent best practice. We know we're subject to audits by HICWA, so at some stage we expect them to be picking up these guidelines as the expected best practice within a hospital. But as I keep saying, there's a lot to run in terms of the implementation process as we reach out to hospitals, identify the senior operational lead who will be responsible within the hospitals for progressing implementation of the guidance, and working with the hospitals about the speed bumps and the barriers that you're going to hit in terms of the implementation process. Okay, just that question there, Linda and Juanita, just about the Gardaí are not required to formally identify the body prior to a post-mortem. Has this been in the acute hospitals for a length of time? Do you want to maybe comment? Or
I think Myra might, yeah.
Dr. So sorry, I can't read the question, but is it a question as to whether the Gardaí are required to attend in a coroner's autopsy, or?
No, so I'll read it out for you, Dr. Does this document identify when the Gardaí are not required to formally identify the body prior to a post-mortem? For example, if the patient has been in an acute hospital for a length of time.
So you distinguish between a hospital post-mortem and a coroner's post-mortem. Best practice in a coroner's post-mortem is that identification is conducted at the hospital by a member of An Garda Síochána to either the APT or the pathologist directing the autopsy. So identification is a very important part of the process. There may be variations around the country. In Dublin district, it is obligatory for the Gardaí to attend. It was suspended during COVID for obvious public health reasons, has now been reinstituted. The only exception in Dublin, and I can only speak for my own jurisdiction, is I do not require it in a maternity facility because the infant has never left the hospital and has had tags applied at delivery. But so there could be variation around the country, and I don't think it's contained in the document, is it, Linda? Reference to it.
I think there is in one part. It doesn't specify, but it does say it varies, and to liaise with your local coroner about the legal requirements. Yeah.
But certainly in Dublin, we require it, irrespective of how long you've been in hospital. It's a more of a legal formality than understanding who the person is.
Great. And then one last question, and then we'll finish up, folks. Is there a formal process of the family appointing a funeral director and informing mortuary in writing mandatory? So again, nothing in these guidances as mandatory, and I don't know if that's touched upon, just that requirement.
I think that, again, from the point of view of the coroner, is that if the coroner has a funeral director, but that's only to convey remains to another mortuary from another place. But the families are entirely at liberty to appoint their own funeral director and communicate to the APT or the mortuary manager who it is that they're using to conduct the funeral arrangements. So that's entirely for the family, and we don't, there's no imposition on them. They've absolute freedom to choose who they wish to have as an undertaker.
Great.
For coroners.
If there's no remaining questions, I'm just conscious of time, and thanks for people for staying with us in terms of just this last piece. And again, apologies this morning about that password piece. So again, to reiterate, we will be posting the video of this for people to review it again, or for people who couldn't attend, that they can watch it back out online. And then number two is we will be progressing the formal implementation of the process in the very, very near future. As I said, encompassed within a broader mortuary improvement program, understanding within the HSE, we know end-of-life care post-mortem is such a significant issue for our citizens and for the public, and it is an important thing that we get right in terms of our care processes. So it's very, very important area from the HSE's point of view. We want to continue to advance improvements in this area, understanding that there's lots going on in the health services as well, but this is a very, very important area. Can I finish off by once more iterating to both Linda and to Juanita and Maureen and the National Quality and Safety Division team? We really, really appreciate this work. I can't believe how well it turned out in terms of the comprehensiveness of the guidance. It has been a fantastic process, underpinned by the patient's voice, evidence, and a lot of talking. I know the amount of work that has gone into this. I was on many of the groups, but there was a huge amount of work that went on in the background. So we really want to thank you thank you greatly for the work that you did. So with that, thank you very much, folks, and for everybody who attended today. And you'll be seeing my face and hearing my name a bit more in terms of the implementation process in the future. Thank you very much.
Thank you.